Today's the discussion will be on proptosis. Before looking into what is proptosis, we have a brief outline about the anatomy of orbit. The orbit is a quadrangular truncated pyramid in shape. The depth of the orbit varies from 42 mm along the medial wall, 50 mm along the lateral wall. At the base of the orbit, it is 40 mm width, 25 mm height. Volume of each orbit is 29 mm. Relations to orbit. Anterior to the orbit is located the anterior cranial fossa. Maxillary sinus is located below. Posteriorly, middle cranial fossa is located, whereas temporal fossa is located anteriorly. The medial wall is formed by the frontal process of maxilla, lacrimal bone, orbital plate of ethmoid bone, and the body of sphenoid. And the floor of the orbit is formed by orbital plate of maxilla, orbital plate of zygomatic bone, and palatine bone. Lateral wall of the orbit is formed by zygomatic bone and the plate of sphenoid. This is the picture which is depicting the relations of the orbit. Here you can see the orbit, and superior to the orbit is located the cranial cavity, and the orbital plate of frontal bone is located here. And inferiorly, the orbit is related to the maxillary sinus, and the nasal cavities, ethmoid bone, ethmoidal axis are located medial to the orbital wall. And there is something called surgical spaces of orbit. What are the surgical spaces of orbit? Some periosteal space, intraconal space, extraconal space, and subtenonal space. What are the importance of these spaces? Are any mass which is arising from the orbit for surgical approach to the orbit, these spaces are important. Looking into the definition of proptosis. Proptosis is defined as forward, that is anterior movement of the globe in relation to the skull. It is measured by protrusion of the apex of the cornea in front of the outer orbital rim. The normal range of the orbit measures from 14 mm to 29 mm, and the average is 16 mm. It means when it is abnormal when it is more than 29 mm as a subsonic reading, or the difference between both the eyes is more than 2 mm. Axial proptosis. Axial proptosis is when the eye is displaced straight outward along the anterior posterior axis or orbital axis. It is found in thyroid ophthalmopathy and intracorneal lesions. Abaxial proptosis. It is also known as non-axial proptosis. Is abaxial proptosis is when the eye is pushed forward and also displaced off the central axis. It is found in extracorneal tumors. Pseudoproptosis. It is seen in cases of high myopia, shallow orbit, or if there is an elevated enophthalmos. Clinical workup. If a patient is presenting to OPD with proptosis, what are the history will elicit? First, we'll ask about the age of the patient, duration of the symptoms, and the onset, how it is progressing, whether it is gradually progressing or sudden or if it is progressing rapidly. If it is a rapid progression, then it suggests a malignant transformation. Then associated symptoms like vision loss, diplopia, pain, swelling, redness, and systemic illness, fast history like thyroid disease, trauma, or malignancies also should be asked for. On inspection, we'll see about the facial symmetry of the patient, about the periorbital fullness, proptosis, globe dystopia, mass, with the mass located, location of the mass, size, face, skin changes, and visible pulsations, and the Valsalva maneuver. On examination, we first look into the facial symmetry, whether the mass is causing any asymmetry of the face. Then we look for periorbital fullness. Here you can see that this periorbital fullness, and it is pushing the orbit downwards. And associated any skin changes and vascular malformations. Vascular malformations can be seen in cases like lymphoma, and this is the patient with xanthogranuloma. On inspection, we also look into the palpebral aperture of the orbit. And in cases of thyroid eye disease, we can see lid retraction with lateral flare. And then we have to look at the position of the globe. There are two ways of looking at the position of the globe. One is the Navigator's view, the other one is Worm's view. In Navigator's view, we look from above, whereas in Worm's view, we look from the down. And we'll compare both the eyes, how the eye is floating. Exactolometry. Exactolometry is also known as proptometry, which measures in an anterior posterior plane the distance between the apex of the cornea and a bony point, usually taken to be the deepest portion of the lateral orbital margin, with the eye looking straight ahead. There are three types of exophthalmometry. One is absolute exophthalmometry, which is compared with the known normal reading. Relative exophthalmometry is the relative distance of the two corneas from the lateral orbital rim. Comparative exophthalmometry, it measures the exophthalmos of an eye at different times. Reverse exophthalmometer. It is a transparent plastic millimeter ruler. The notch corresponds to angle of lateral orbital rim. A scale readings varies from 0 mm to the end of the notch to 40 mm. Parallax is minimized by using scale on both sides of the rod. Nichols exophthalmometry. Fixation point slightly above and below the orbital rim. Employs pupillary position as mechanism for adjustment of patient's exophthalmos. Relies on interpupillary distance as base measure. Parallax is used to determine the degree of proptosis. It is a type of comparative form of exophthalmometry. Proptosis exophthalmometer. The patient must be on the same level, eye to eye, with closed eyes, but with the orbital notch on the temporal side of the orbit. The separation of the exophthalmometer is very important and must always be noted. The patient is then told to open their eyes and look straight ahead. This is the picture depicting the exophthalmometry, Hertz exophthalmometry. In this picture, you can see these two points which will sit on the lateral orbital rim, that is lateral orbital rim, in the orbital notch. And with that, base is kept constant and the exophthalmos is measured by avoiding parallax. The limitations of these exophthalmometry are for fixation, depressed or fractured lateral orbital rim, convergence errors, and head movements will affect the trustworthiness of your readings. The findings are recorded in the following maneuver. The base is kept constant as H105, and the right eye reading is measured as like 18, and the left eye reading is recorded as 19. The expected normal ranges are for Caucasian males it is 12 to 21, Caucasian females it is 12 to 20, African American males it is 12 to 24, whereas African American females it is 12 to 23. Then we look into the tumor surface. Tumor surface will look for prominent vessels, any nodularity, ill-defined ulceration, destruction of surrounding structures, etc. Then conjunctival or fornical examination. We look for any vessels in the fornices in case of any veno-lymphatic malformations and congestion. Then we look for size of Valsalva maneuver. The veno-lymphatic malformation tend to increase in size with Valsalva maneuver. The other features are visible pulsations we have to look for. On ocular examination, we have to see for best corrected visual acuity, extraocular motility, anterior and posterior segment. We have to look for optic disc edema, atrophy, shunts, retinal folds, etc. And pupillary reactions. If there is any nerve compression, or nerve compression, there can be anisocoria or pupillary reflexive reactions will be sluggish. Then on palpation, we should start with the orbital rim. We should first relax the orbital septum, feel with the finger. Then we have to look for the location, extend borders and fixate the bone, temperature, tenderness, surface, consistency, the surrounding bone, retroflexion test, pulsations of the tumor or group, AP malformation, bony defect as in neurofibromatosis, and for example, in neurofibromatosis, there will be absence of sphenoid dysplasia will be there. On systemic examination, this is, for example, is a case of neurofibromatosis where there is neurofibroma of the upper eyelid, associated Coffey spots are there. Bilateral proptosis in adults are most common possibly thyroid eye disease, lymphoproliferative disease, and cavernous sinus thrombosis. Whereas if a child is presenting with bilateral proptosis, we have to think about leukemia, neuroblastoma, pseudotumor, or orbital cellulitis. So if a mass is presenting since birth, it can be encephalocele, meningocele, teratoma, hemangioma, or hematoma. If a child is presenting to us, it can be benign lesion or it can be a malignant lesion. If it is a benign lesion, it can be dermoid, lymphangioma, or capillary hemangioma. Or if it is a malignant lesion, it can be orbital retinoblastoma, rhabdomyosarcoma, neuroblastoma, and leukemia, that is scleroma, or optic nerve glioma. In adults, it can be a benign lesion or it can be a malignant lesion. The benign lesion or thyroid eye disease, cavernous hemangioma, malignant lesions can be lacrimal gland tumor, pseudotumor, orbital varix, leukocyte, dermoid, and lymphoma. Imaging. CT scanning is used as a primary imaging technique for evaluation of any patient with proptosis except retinoblastoma, and USG should be done in all cases. MRI done in case of tumors extending up to orbital apex. Incision or excisional biopsy is done after CT. Ultrasonography. Orbital ultrasonography should be used to visualize anterior and middle orbital lesions. A good check. Adjunct to CT scan. Solid or cystic lesions, heterogeneous or homogeneous. Counter CT scan. Axial, sagittal and coronal cuts of orbit, head and paralysis sinus are essential for evaluating the exact location and extent of the lesion and planning for surgery. This is the lesion which is in osteosarcoma. Contra CT scan. It is helpful in showing the relationship between the orbital mass and the surrounding bones, and also to differentiate between the orbital mass and the optic nerve, where the mass is situated, its relation with the brain and the paranasal sinuses. Also, it helps to tell us whether the mass is encapsulated, unresectable, or diffuse, and also tells about the vascularity of the mass. MRI. This is an MRI picture of meningioma. MRI will show in meningioma. It shows the relationship of the tumor with the optic nerve, the infiltration of the surrounding structures, superior to CT scan detected intracranial extension of mass lesions and orbital apex lesions. So now we'll be looking into the common etiologies of proptosis. And the first most common entity, which is often is common in children, or orbital cellulitis. It is infection of the soft tissues in the orbit, posterior to the orbital septum. The causes can be non-hemolytic streptococci, staph aureus, or H. influenzae. The focal of infection would be most commonly the neighboring structures, which is nothing but the sinuses, lacrimal sac, and skin. Or if there is any pre-existing orbital disease, sometimes a systemic sepsis can also spread, which have a hematogenic spread. Chandler's classification is used for classical orbital cellulitis, and the extent of the disease is evaluated with the help of MRI. So this is the difference between the orbital cellulitis and preseptal cellulitis. In preseptal cellulitis, you can see the severin is restricted to the orbital septum, whereas in orbital cellulitis, where it is diffuse and there is no restriction, and it can extend beyond the orbital septum, and it can sometimes extend up to cavernous sinus and can cause cavernous sinus thrombosis. Dermoid cyst. Dermoid cyst, it is a cyst lined by squamous epithelium containing T squamated cells. The contents of the cyst were sweat, sebum, desquamated epithelial cells, and hair. The cyst can be either congenital or acquired. Congenital cyst is situated along the line of embryonic fusion, either of the midline of the body or face. And the formation of the cyst will be, it follows a sequence like the dermal cells sequestrated in subcutaneous skin. They proliferate and liquefy, and they will form a cyst. And this cyst will grow and indents the mesoderm, which is the future bone, and it will cause bony defects. Depend on the site of occurrence, we can call it as external and internal angular dermoid. The fusion line, these are seen along the fusion line of frontonasal and maxillary processes. So these patients will present to us with painless, low-growing swelling. The swelling can be a soft, cystic, and fluctuant swelling where transillumination will be negative. The underlying bony defect will help us in diagnosing the location along the line of the fusion. CT scan will show a well-defined non-enhancing lumen and enhancing wall bony changes. And the CT scan will also show fossa formation, bone erosion, and bone sclerosis. The MRI will show a cystic lesion which is hypo on T1, hyper on T2 with rim enhancement. That is, the lumen will be non-enhancing, whereas there will be rim enhancement. This is the picture of a dermoid. This is the clinical picture where the child is having external angular dermoid and this child is having an internal angular dermoid. This CT picture is showing bony erosions here, and also there is fossa formation. Then the next informal entity is capillary hemangioma. The capillary hemangioma is the most common tumor of childhood, and it's 75% of cases it is detectable by 4th week of life. The risk factor for capillary hemangioma are prematurity, chorionic villus sapling, and the site is most common site is upper lid, followed by lower lid and orbital margins. The systemic associations with capillary hemangioma are Cashback-Merritt syndrome, Face syndrome, visceral involvement will be there, and the visceral involvement is seen along with association with liver. MRI will show a post-septal involvement. The T1 image will show a moderate intensity, whereas T2 weighted image will show a hyper intense. And there will also be post-contrast intense and homogeneous enhancement. Then lymphangioma, which is a benign congenital vascular malformation. It is a low flow malformation. There will be a history of URTI, followed by the already increasing size of the swelling. May involve conjunctiva. The conjunctiva will show dilated lymphatic vessels. Eyelids are defibrid, usually identified prior to teenage years, usually slow enlargement and increasing proptosis. If there is sudden onset of proptosis, then we should suspect any hemorrhage into the cyst. That is nothing but a chocolate cyst. And there will be no enlargement with Valsalva. CT or MRI shows multicystic, ill-defined, non-enhancing lesions. Ocular cysticercosis. In 5% of cysticercosis, ocular involvement will be there. The organism responsible for this is will be tinea sodium. The patient will be presenting to us with gradual painful onset diminution of vision, and the ultrasound will show hyperechosis corresponding to scolex. The CT will show it depends on stage of evaluation of infestation, vesicular stage, where there will be viable hypodense non-enhancing lesion will be there, colloid stage, where there will be peri-lesional enhancement of edema, nodular granular stage, where there will be nodular enhancing lesion, then active parenchymal stage, where the scolex within a cyst may appear as a hyperdense dot, then calcified stage, where we can see calcification. Serology, that is ELISA, also helpful in diagnosis of ocular cysticercosis. This is the child with ocular cysticercosis, where extraocular muscle is involved, and the child is having difficulty in movements, of eye movements, and ophthalmoplegia is there. This is the ultrasound picture, where we can see a hypoechoic area with hyperechoic area. This is the cyst, where this hyperechoic area corresponds to the scolex. This is the MRI picture, where there is location of the cyst in the extraocular muscles. Hydrated cyst. It is caused by echinococcus. The orbital cyst. The patient can present to us with proptosis and exposure keratopathy. There can be limitation of extraocular movements in the optic atrophy. The ocular symptoms are rare due to enlargement of cystic orbital cavity. The ultrasound will show a double wall sign and volume cavitation. Rhabdomyosarcoma. It is the most common malignant tumor in children. They present in the first decade of life. It is a rapid unilateral proptosis and globe displacement. The CT scan will show irregular margins and often monodestruction. The MRI will show a bright T2 signal. The diagnosis is confirmed with a biopsy or excisional biopsy. Histologically, it can be divided into 4 main types: embryonal, alveolar, pleomorphic, and botryoid. Embryonal type is the most common, occurring in 2/3 of cases, whereas the alveolar type is the second most common, but it is the most malignant type with a high frequency of metastasis. The pleomorphic type is the most differentiated type with the best prognosis. Then other condition which is common in children is leukemia or granulocytic sarcoma. It is second to rhabdomyosarcoma in frequency in children. Granulocytic sarcoma, also known as scleroma. Why it is scleroma? It is due to the green color, which is imparted by the myeloperoxidase in the tissues. It is a localized mass, extramedullary form of AML. The mean age of presentation will be around the age of 7 years. Multiple soft tissues will be involved. The other thing which can be involved are lacrimal gland and bones. In 10% of cases, it is bilateral. Leukemia, unilateral is more common. There may be soft tissue infiltration or hemorrhage in myeloid type, whereas lymphoblastic type, the orbital involvement is more common than in acute stages than in chronic. Thyroid ophthalmopathy. Graves' disease is a multi-system disorder which is characterized by hyperthyroidism associated with diffuse hyperplasia of the thyroid gland, infiltrative ophthalmopathy leading to exophthalmos, infiltrative dermopathy with localized tibial mesothelioma. Extraocular muscles are the site of the most clinically evident changes in these patients. Muscles are enlarged with dense lymphocytic infiltration. Retrovalvular fibroblasts secrete glycosaminoglycans, which causes interstitial edema. More than 50% of patients with Graves' disease have eye complaints, only 5% warrant intervention. Therapy is still primarily directed at manifestation of the disease in a palliative fashion. Many patients are euthyroid at the time of eye symptoms appear, although further testing usually reveals dysthyroidism. Cavernous hemangioma. It is common in adults. It is a well encapsulated, well tolerated mass. And the ultrasound will show well defined round tumor with high internal echoes. The CT scan will show late enhancement with contrast. MRI will be hypo-intense to fat on T1 and hyper-intense on T2. The pathology will show a grassy encapsulated lesion. On microscopic examination, there will be large congested vascular spaces, and the electron microscopy will show endothelial cells encased by muscle cells. Lacrimal gland tumors, pleomorphic adenoma. It is a tumor in younger age. The patient will present with painless proptosis, more than 1 year, and downward globe displacement, and pain is seen in less than 10% of cases. It is a benign tumor, and the imaging will show a CT with well circumscribed tumor, excavation or fossa formation of the adjacent wall. So you can see the tumor here where there is excavation and fossa formation. There will be globe indentation. Here you can see where it is indented the globe, and the calcification may be present or not, and it is with contrast it shows some bright enhancement. See, this is bright enhancement with contrast. Then adenoid cystic carcinoma, it is a malignant tumor of the lacrimal gland. It has a bimodal occurrence in second and fourth decade, and the proptosis is of very short duration, that is less than 1 year, and the pain will be more common, that is 30 to 80% of patients will have pain. This is gland paresthesia. This is due to perinatal environment. It is a well-defined invasive tumor, likely lesions or irregularity or defect in the adjacent bone, extension towards the apex of the orbit or in the brain, and there can be associated calcification. Lymphoma, primary or secondary to systemic disease, most patients present with localized orbital disease will develop systemic lymphoma. Incidence between 4 to 13% of all orbital tumors. Non-Hodgkin's lymphoma is the commonest. It is usually unilateral, and the age group will be elderly age group of 50 to 70 years. It involves superior and anterior orbit, predilection for lacrimal glands. Systemic association of lymphoma should be ruled out. So this is a homogeneous mass. It's a lobulated mass on CT and MRI. They moved around the normal structures without deforming them and typically do not erode adjacent bones. Orbital pseudotumor. It is an idiopathic orbital inflammation, excludes systemic diseases, sarcoid, thyroid, autoimmune, and vaginal disease. Second to seventh decade, the age of presentation of pseudotumors will be second to seventh decade. There will be multifocal involvement of any orbital structure anywhere in the orbit, either it can be focal or multifocal. And the typical feature is both the tendon and belly are involved. We just have to differentiate from thyroid ophthalmopathy, and that can be associated uveitis. On ultrasound, if the patient is having an associated uveitis, we can see these signs. And uveitis, associated uveitis also will be there in case of orbital pseudotumor. This is the picture. The patient will have a proptosis, which is a acute onset on a few days. The eyelid swelling, chemosis, and diplopia will also be common. Visual loss with optic nerve involvement. CT findings clearly enlargement of affected structures, and the treatment will be rapidly steroids, immunosuppressants, and if it is not responding to steroids or immunosuppression, then we can also give low dose radiation therapy. This is the picture of a Abradus protein where you can see both the muscle and the belly. Both are involved. Sorry, the belly and the tendon both are involved. See the muscle and belly both are involved. It is causing a proptosis here. That's all the discussion for today. So we can end up here. We can end up here, right? Thank you, everyone.